Hello there, this is Dr. Brian Buchanan bringing you this eFast tutorial on detection of pneumothorax with lung ultrasound. We have some specific learning outcomes for this tutorial. Focus on developing a consistent approach to performing and interpreting lung ultrasound, to examine for pneumothorax, troubleshooting the absence of lung sliding, and detecting procedural complications immediately at the point of care. You may be surprised to know that the sensitivity of chest x-ray for pneumothorax is around 45%. It's variable depending on the study, but is lowest in the supine patient, and that is air collects in the most anterior or superior airspace. Lung ultrasound has sensitivity approaching 90 to 100%, which means it's extremely sensitive to pneumothoraces. The standard thoracic trauma ultrasound exam is an 8-point examination. That's 4 on each side of the thorax. We're really going to focus on points 1 and 2, and that's for the detection of pneumothorax. The probes most commonly used for this examination include the phased array probe, which has a low footprint and spreads out in a fan shape, and the linear probe, which is higher frequency and allows for better visualization of the pleura. The convex probe can also be used and will cast over multiple rib interspaces. Typically the probe is held with the probe marker facing towards the head, and it's held in the sagittal/parasagittal plane. We can see in this 2D image here, we have a rib-lung-rib image. Again, you'll notice the marker is on the left side of the screen, and the depth is around 11 centimeters. We're going to review 5 important findings that you will find very useful to apply in the trauma bay. Lung sliding, A lines, lung pulse, lung point, and B lines. Lung sliding is shown here. This is the apposition of the parietal and visceral pleura, which are sliding back and forth as the lung undergoes insufflation. This is a scintillating hyperchoic line, which is seen nearest the probe. This means the pleura is unfused, and there could be no intervening airspace. Because this is a tissue-air interface at the pleural line, it causes a reverberation artifact, which tends to duplicate the pleural line beneath the original pleural line. Notably, everything distal to the pleural line in the far field is all artifactual. Normal lungs typically have good lung sliding and A lines. We can use this for post-intubation confirmation of tracheal intubation and to exclude pneumothorax. It can also be used periprocedurally before and after performance of central lines and thoracocentesis to rule out pneumothorax immediately. The absence of sliding is non-specific. We know pneumothorax is obviously a cause. We can see in this image here, this is a silent pleural line, and there's no scintillation occurring. Obviously, with main intubation, which is more likely to occur on the right, we can see a lack of sliding on the left. Apnea, of course, because there's no pulmonary insufflation. With significant localized pathology like pneumonia atelectasis, we can see a lack of sliding, generally in a focal area. This is often accompanied by other signs. In the patient who's had chemical pleurodesis, or the patient who's had occur post-surgical, like after a VATS, you may see a particular area of lack of lung sliding. This is often accompanied by a scar on the external surface. On the image left here, we see no sliding. On the image to the right, we see active sliding. The presence of sliding will rule out pneumothorax 100% at that site. And so generally speaking, you'll need multiple sites to ensure the complete presence of sliding. And you really need to consider position of thorax during the scan. In a supine patient, such as in this CT scan here, we can see the collection of a superior pneumothorax. And note that in the anterior portion, there'll be lack of sliding. If we scan more posteriorly, we'll see the presence of sliding. And so it makes sense that there'll be a point of mixed pleural apposition and non-apposition. This is often seen as the lung point, shown in this demonstration here. We can see in this particular area there is sliding, next to an area of non-sliding. This lung point is highly specific in pneumothorax and increases your accuracy to about 90 to 95%. Again, be aware of position during assessment because air rises to the non-dependent areas of the thorax, and so if they're supine, it'll be the ventral or superior area of the chest. If they're sitting upright, it'll be more towards the lung apex. Again, lung ultrasound has extremely high sensitivity for even small pneumothoraces. And so pneumothorax that may be missed by chest x-ray may be picked up by lung ultrasound and requires greater caution to whether or not it truly requires an intervention. Great, so maybe you found a lack of lung sliding, maybe you found a lung point. Well again, it has very high sensitivity, so it requires some clinical correlation. If the patient is not on oxygen and they're not short of breath, you may think twice about whether or not that patient needs an immediate surgical or procedural intervention. And if the patient has significant hemodynamic or respiratory compromise, the patient may need a needle thoracostomy and chest tube at the time of finding such pathology. Nevertheless, a CT or chest x-ray may still be required to assess the mediastinum, ribs, vascular structures, and many other structures. In select circumstances, if a patient is in profound hemodynamic or respiratory compromise, bilateral chest tube may be placed regardless to cognitively offload, as pneumothorax can be a contributor to hemodynamic instability. There are some other findings to rule out pneumothorax. The first one we'll talk about is lung pulse. Here again we see lung pulse. This is movement of the visceral and parietal pleura against one another, but this is not truly lung sliding. This is movement of the pleura as a consequence of cardiac oscillation. This is more often seen on the left than compared to the right, and can be demonstrated in normal healthy patients with periods of breath holding. Here are thoracic B lines, which reflect thickening of the interstitial pleura. This can occur secondary to things like pulmonary edema and ARDS diffusely and pulmonary contusion more locally. These are thin hyperchoic lines, almost like a flashlight, that radiate from the pleural line all the way down in the near field to the far field. They move the pleural line, and they generally dominate over A lines. So again, both of these findings will rule out pneumothorax at a particular site. There you go. There's 5 important lung ultrasound findings, from lung sliding to A lines to lung pulse to lung point to B lines. Thank you for listening.